Welcome to Key Insights. Today we will highlight about European perspectives in lung cancer held at the beginning of March in Madrid. Today with me, I'm pleased to introduce Dr. Paz-Ares, that is one of the co-chair of the meeting. And we would like to focus this dialogue around immunotherapy, that is the rising star in thoracic oncology, and not only in thoracic oncology, but also to focus a little bit about the latest achievement in the field of targeted therapies. So, let me start with immunotherapy, and I would like to ask you, Louis, do you believe that immunotherapy is a turning point around the therapeutic strategy of lung cancer in general, and specifically of non-small cell lung cancer?
Yeah, I think, I would be positive on that question. For a number of years, we were somehow using chemotherapy. I think we somehow learned to get some benefit from it. Later, targeted therapy also, we had some improvements. We have the impression that we are somehow having not big thresholds to discover there. And now immunotherapy is kind of giving us a new horizon. I think at the present time we are just at the beginning of the history of immunotherapy in lung cancer. We are somehow, or we were very enthusiastic about the early results. I think that's fine. The truth is that they are only benefiting a minority of patients. Still, we don't know for how long, but the good thing is that we are at the beginning of the exploiting immunotherapy in lung cancer.
Well, we need to rely our treatment decision on outcomes. Okay?
Right.
And obviously, as you said, we are getting responses in 20-25% of the patients in the overall patient population. We are getting some improvement in progression-free survival. Sometimes we are getting good or excellent hazard ratios. But what is, from my personal point of view, is more impressive is the 1 year and even the 2 years survival rate. That is true from the mature data that we have in second line, but we have also promising data in front line. How do you feel, how you would suggest to make a reasonable judgment to a practicing physician to assess on his own patients the activity of these agents?
Well, I really quite like the summary you have made about we are getting particularly good data in terms of 1 year and 2 year survival. So we got quite promising mid-term data. We haven't got that mature long-term data, which is one of the uncertainties right now. And so this is very important for our patients when we talk about the potential benefits. So it's not only living some extra months, but having a good chance of being, let's say, for 2 years around and with good quality of life, maybe 3 years. Still don't know if those patients are going to be able to be long-term. For many of our patients, this is more important as compared to having an average 2 or 3 or 4 more median survival, which is okay, but is not that important for many of the people. So I think this is very important. So at the time of assessing or inciting what a drug is given, particularly immunotherapy, I think it's very important to look at these midterm endpoints as compared to just median survival, which was a typical way we compare one drug to the other in the chemotherapy and targeted therapy times.
So looking to the future, there are several questions. Point number 1, do you believe that we can combine immuno checkpoints with chemotherapy in front line?
I mean, of course, it's true that we can do it. I have to say that I was not a big supporter of such a combination. I thought there was not really very good science behind. I have to say that after seeing particularly the data of the randomized trial with pembrolizumab, I have to admit that the data is data, and I think I'm a bit more enthusiastic. Still, the question we'll have to answer is that it's better to combine them as compared to giving one after the other. Particularly, is that true for all comers, or we just should give chemotherapy plus immuno in a small subset? So those are questions that are needed to be addressed. But still, on the other hand, I would be more happy about researching or investigating some other combination. I don't know, what do you think? Don't you think like immuno combos or some targeted therapies with immuno is not?
Well, this is something that obviously it's partially related to my next question to you. That is mainly mainly concerning the toxicity profile of the combination of immuno and chemotherapy. And consequently, if I am looking to the scientific rationale of sequencing chemotherapy and immunotherapy or the other way around, it could be also related to the level of PD-L1 expression.
Yeah.
So it could be that in those tumors that they have a low PD-L1 expression, I will start with chemo, that potentially will induce an antigen release, and then I will follow pretty soon with immunotherapy. For those tumors that are PD-L1 high, I would like to start with immunotherapy and then to consider chemotherapy. But this is, in a second time, this is just a part of a hypothetical scenario, what a clinical researcher should do. But let's come back to the question. You have a huge experience using these drugs, mainly across clinical trials. So you can give to the practicing physician your opinion or your view about the toxicity profile of these agents across the board, not specifically to one.
So, yeah, I mean, I would say that overall, I mean, those particularly PD-1 and PD-L1 agents, altogether, they are not very different one to each other in terms of toxicity. I would say tolerance is a lot better as compared to chemotherapy, globally. Still, some 20% of the patients, 15 to 20, they get some immunological side effects. They are lacking, for most of the cases, of general toxicity as compared to chemo and targeted therapy, but they got these immunological side effects that I think is very important. Users of this type of treatment should know about, and they should be able to recognize it early and to treat it properly, particularly important. Only 5% of the patients do get severe immunological side effects, but still 15 to 20% of the patients got some side effects. So it's important to recognize it early, particularly endocrinopathies, particularly hypothyroidism, rash, pneumonitis, less frequently, transaminitis, colitis, etc. When we talk about some other immunological agents, such as anti-CTLA-4 agents, here toxicity sometimes is more severe, particularly immunological side effects, particularly some type of endocrinopathies, hypophysitis, some type of colitis, etc. And it's really more and more important to set up the correct context to treat our patients. We have to get good pathways to handle those patients when toxicities appear, to the right specialist, to the immunologist, to the endocrinologist, etc.
So in principle, you are talking about a multidisciplinary approach.
Totally agree.
Before leaving this topic of immunotherapy, I would like to ask you what you see in the near future about biomarkers in this field.
Okay, I think that is very important. At the present time, we just got in lung cancer the PD-L1 expression in tumor, which is, I would say, a reasonable biomarker, particularly to predict benefit is not that good to predict absence of benefit, but still we have to improve that. So I would say a multidisciplinary, a multivectorial biomarker would be a lot better, taking into account the cells that are in the immune landscape of the tumor, maybe the mutational burden. That is something very easy to get nowadays.
What about the immunoinfiltrate?
Yeah, absolutely. I was referring to the landscape, cell immune landscape by that. I think that's very important. If that is how many TILs you got, how many of other cells you got, which type of TILs are you getting, those are Tregs or these are CD8 or whatever. So I think those are very important questions. So possibly in the future, when you have a tumor and there is no TILs, maybe the first thing you have to do is try to get the TILs inside. And that maybe through an anti-angiogenic, you have issues like there is downregulation of the major histocompatibility complex, so you need maybe to help the antigen presentation. In that case, maybe, I don't know, a MEK inhibitor or a BRAF inhibitor is a good opportunity here. So I would see that in the future we will learn a bit more about what is the main mechanism of escaping, and then we should tackle more pathogenically the immunotherapy. Because at the present time, I would say we are just at the start.
So, in principle, your last sentence was helping me to drive to the second part of this activity, that is focusing on oncogene-addicted tumors,
right.
And for those targeted therapies that are already available for our therapeutic armamentarium. And I would like to focus on mainly our discussion on the third generation EGFR TKIs that recently became available, and on second generation ALK inhibitors. So across the board, if you can briefly summarize what are the unique features of these two classes of agents, the third generation EGFR and the second generation ALK inhibitors, compared to the parental compounds?
So the beauty of those drugs are that they are tackling the mechanism of resistance. Typically, the mechanism of resistance involves a change in the conformation of the ATP pocket of the oncogene-addicted kinase, and so that the first generation TKI is not anymore binding with high affinity. So these third generation type of drugs had been designed to really bind with high affinity to this new conformation of the ATP pocket. So it's really a fantastic way of in terms of conception, right? The good thing is that they are actually, in many cases, more effective than even the parent compound they look like, and toxicity-wise, very often they are also quite favorable. So I think that is kind of a success. It's only helping a reduced number of patients, but it's really fantastic achievement, I would say.
So let me focus a little bit more on this clinical features. So the third generation EGFR TKI, and specifically we have only one that is osimertinib, and the second generation ALK inhibitors. They look much more potent against brain metastasis.
Yeah, I think this is another issue which is very important. First generation TKIs were not particularly good pharmacokinetically wise reaching the brain, and that was one of the reasons that for those two diseases, ALK positive and EGFR mutant lung cancer, that they have a natural particular propensity to go into the brain. That was the reason why very often the brain was the site of progression. because not only the natural history of the disease was tending to go to the brain, but also the drugs were particularly bad at the brain. They were not reaching there very well. It looks like this new generation, they are getting a lot better there.
Listen, osimertinib has been registered with, let me say, what in principle they are called liquid biopsies, so the assessment of the T790M mutation in the blood. Can you briefly argue of this liquid biopsy versus solid biopsy, not specifically and only for osimertinib, but in general, giving to the audience your short and long-term perspective on liquid biopsy?
Okay. So, summarizing a bit, I see that a liquid biopsy is a fantastic opportunity, having a non-invasive method of diagnosing the genotype of a patient at a given time point. And this is fantastic. And indeed, you got an EGFR mutant tumor that is progressing to a TKI. You're taking a blood test, and you find in the free serum DNA, you find the mutation. You can start osimertinib with very high chances of getting a nice benefit. There are two issues that worry me a bit. One is that if we are not getting the tissue, maybe we are losing opportunities for the future to learn the new mechanisms of resistance. The second thing which I'm a bit worried about is about quality control. When we are doing that at the current stage in hospitals, if there are no quality control programs into that. Indeed, I have experienced that I have several negative cases that then rechecked elsewhere, they were positive. So I'm a bit worried about that.
Well, let me say that there are also useful things, like for instance, liquid biopsy is giving you an average idea of the mutational load, as well as is giving a much more dynamic idea of the way in which the clonality of the tumor is changing.
I couldn't agree anymore. So you're having really the possibility of genotyping timely. So to see how the disease is evolving, particularly taking into account the stress the drug is inducing to the tumor, and then you see the genotype, how it's evolving, and then you could really adapt your therapy based on the genotype.
So today in this activity we were discussing a little bit about the role of immunotherapy in lung cancer, as well as the latest achievement in the field of targeted therapies, again in thoracic oncology. I would like to thank Luis Paz-Ares for attending and for discussing with me today. I would like to thank you for participating in Key Insights.